let us know what your role is in your hospital. Give us an idea of what, see if I can move this out of the way. I don't know if you can see that. So while this is up and you guys are responding, it looks like we have a lot of pharmacists on the call, which is kind of what I expected. And hello to our infection preventionists out there too. I'll just, while people are having a chance to respond to this, I'll just let you know a little bit about my background. I am a pharmacist. I did a pharmacy practice residency. I am board certified pharmacotherapy specialist. I worked at Barnes-Jewish Hospital for about 5 years, and then I moved out east and I worked in a community hospital that was licensed for about 300 beds. We usually had a census of around 200 people. I was the clinical coordinator out there. At the time that we were doing antibiotic stewardship, I was working part-time, and they came to me one day and we knew we needed to start this program. But my boss came to me one day and said, we need you to figure out how we're going to do antibiotic stewardship here. And like many of you, I'm sure, they didn't take anything off my plate. They just added this responsibility to my plate, and I had to figure out what we were going to do with it and how we were going to manage this. So where to start? The first thing I did was go out and get as much information as I could about what is required. At the time, the Joint Commission standard was not in place, but we knew that it was coming. And so we were looking at the guidelines, we were looking at all the recommendations, I was trying to gather as much information as I could about how to do this in a community setting and how to do it with the people that I was working with, because I was not really given any additional resources to do this. And so I've got a few slides here that have some online resources. And I put these here. We'll send out after the presentation today. I'll put these in a handout so you guys can have some of these websites. But I wanted to let you guys know these are out there if you don't already know about them. Obviously, there's a Joint Commission standard that has to do with antimicrobial stewardship. But the Joint Commission resources put out an antimicrobial stewardship toolkit that is available online, and it is really, really useful. If you haven't looked at it yet, I recommend that you do that. It has 5 modules in it. There's a lot of great detail in it. There's a module about infection prevention and control and how that links with antimicrobial stewardship. There's a module about developing a business plan so that you can communicate with your administrators in a language that they understand to maybe help you get some more resources. There's a module about putting your team together. There's a module about how to create change in your institution. It's a really, really good, has a lot of good information in it. And then there's a whole module about metrics and how you're going to measure your impact. And so this is really, really good tool. The CDC, of course, has some information out there. I included 2 specific links. One is a link to a page that is all about implementation and core elements in small and critical access hospitals. There's a lot of good information there. The second one is a link on the CDC website that it goes has information about antibiotic stewardship programs that are up and running and in place. Most of them are at larger tertiary care centers, but they're sharing their information. So if you're in a position where you're trying to develop some tools or you're trying to see what some other institutions are doing and what their stuff looks like, there's links to programs that are up and running, and you can kind of just get an idea, maybe get inspired, get some good resources there to see what some other hospitals are doing that have programs in place. The IDSA, of course, is sort of the go-to place for practice guidelines. They have a guideline on antibiotic stewardship programs, but they also have all of your treatment guidelines as well. So if you're developing a guideline for your hospital on skin and soft tissue infections or some other type of infection, that's the place to go for your guidelines. Some additional resources. SHEA is the Society for Healthcare Epidemiology in America, and they have a really good site that has links to all kinds of good information. The National Quality Forum has this really great antibiotic stewardship playbook. It was put together by many leaders of antimicrobial stewardship across the United States. Our own Jason Newland was a part of that. He's a part of our group as well. it's a lengthy document, but it's got lots of good information in there about barriers and how to overcome barriers. It's got information about how to sort of take your stewardship program to the next step, maybe places to start, and then once you've kind of got that down, how to go to the next level. Some really, really good information there, so I highly recommend that document. For the pharmacists that are listening, if you are a member of ASHP or ACCP, they have good resources. If you're not a pharmacist, I'm certain that the other professional organizations have this as well, but joining listservs for your professional organizations is a really useful place to go to get information and connect with other people who are doing the same kind of work you're trying to do. And then there's more resources out there as well. There's the certificate programs. The MAD ID is making a difference in infectious disease pharmacotherapy. That is one certificate program. I know the SIDP, the Society for Infectious Disease Pharmacists, has a program as well. These programs are really good. I know the MAD ID program has some basic ID kind of pharmacotherapy, basic ID knowledge modules. It's got antibiotic stewardship modules, and then there's sort of a practical component to it as well. So those are great places to go if you're looking to, you know, get prepared to run your antibiotic stewardship program. Go to your meetings, your professional meetings. There are meetings. I know MAD-ID has an annual meeting all about antimicrobial stewardship. At your professional meetings, there's most likely frequently breakout sessions or other webinars offered on antimicrobial stewardship because it's such a big topic. You know, look to the primary literature. There are more and more reports of community hospital experience, so you can kind of see what's working for people across the country. And then networking, like we're doing here with our collaborative, just connecting with other people who are sharing your struggles and trying to do the same type of work. It's good to talk with others who are focused on the same things you are. Make those connections. So what I wanted to do, in addition to just sort of pointing you to those really great resources that are out there, I wanted to share some of my experience. And so, as I said, I was responsible for starting our stewardship program. This was a few years before the Joint Commission mandate was in place, or the Joint Commission standard was in place. And these, I would say, are the 5 things that I did or we did that probably helped us the most. And so we're going to start by talking about your physician champion and how important that is. So I wanted to ask you, do you have a physician champion? And if you do, is it an ID physician? Is it maybe a physician who's not an ID specialist? I know not all the hospitals have ID specialists available to them. Or do you not have a physician champion? While you guys are putting in those results, I'll just tell you a little bit about my experience. It's kind of unique. In the community that I was in, we were kind of geographically isolated. The nearest larger hospitals were over an hour away from us. We had 2 ID practitioners in our community, in our whole county. They happened to be married to each other, so that made for some very interesting politics. And they had been in practice there pretty much their whole careers. They had been there for at least 2, probably closer to 3 decades, that they had been the only 2 ID practitioners in the area. They had a private practice. They did consults at the hospital, and one of them ran our infection control and prevention committee, and the other one was the chair of our P&T committee. So as sort of the administrative people in our pharmacy, we worked very closely with them. Our staff pharmacists, you know, didn't have as much direct contact with them. And I will say they were really smart. They were really good at what they did. They took excellent care of their patients. They were very intimidating though. And everybody, including the younger folks, the newer staff at the hospital, were kind of afraid of them. And I will have to say our pharmacists would openly say that they were kind of afraid of them as well. So I knew when we were developing our antibiotic stewardship program, because these 2 physicians were so respected by the medical staff and the administration, and they were our 2 experts in the area, they were going to be a part of our antibiotic stewardship program. Luckily, they were super supportive and really wanted to make this work. But we could not have had a successful stewardship program without their input. So I'm looking at your results here, and it looks like, you know, a little over a third of you have an ID physician champion. So that's kind of the ideal. 44% of you, it looks like, who are responding do have a physician champion, but they're not an ID specialist, and that's kind of our next best option. And in some cases, it's your best and only option. And it looks like we've got almost 20% of you there that don't have a physician champion. So I would say finding a physician champion is really important. If you don't have one, you know, you need to probably put a little bit of effort into figuring out who can work with you. And I know that not all of you have an ID physician available. You know, maybe there's a physician that has just a lot of influence and is respected by your medical staff, or maybe has some other influence, like a chief medical officer who kind of oversees people who might be able to support you. Hospitalists are sometimes good choices because they're really plugged in and networked with all of the prescribers that are coming to your hospital. So if you can get them on board. If you don't have anyone locally, you know, you can connect off-site with people. There are telemedicine programs. Certainly being part of, you know, being connected to a collaboration like us is a good thing. But if you have a physician who can help you, that's going to be ideal. I will say too, if you're part of a health system, connecting with your health system, some health systems like Helen, who's on the call with us today, she's a pharmacist, but she's running she kind of coordinates antimicrobial stewardship for the BJC health system. So you may have resources like that in place that can help get you connections, or at least get you support. In the absence of that, you know, looking for an administrator to support you, that's going to be important or helpful. And this link at the bottom, it's back to the antimicrobial stewardship that the Joint Commission Resources put out, their toolkit. This list on the right is sort of some characteristics in a good champion that you would be looking for. So somebody, some physician, does not have to be ID if you don't have that available, that has good leadership skills, can be a good politician for you, because politics are real in a hospital. And you need to have somebody who's going to be effective. An effective communicator, somebody who's, you know, uses evidence-based medicine, they're respected by the medical staff and the hospital administration. Ideally, someone who sees patients. These are the types of characteristics you're going to look for. So whoever you've got who has most of these characteristics, or at least some of them, that's who you're going to want to try to connect with. And I will say, you know, if you develop a passion for antimicrobial stewardship and there's a physician who maybe they're not that excited about it, but they have a lot of these attributes, if you can share your passion with them, sort of inject some of that passion and get them excited about it, that may be a good way to go. So they may not be excited about it and that into it right now, but if you can share some of the potential of your program with them, they may be willing to help you. So you have to exercise a little bit of persuasion there sometimes to get people to help. But having a physician champion is really important.
Erin, I think that's a great point. I was wondering if, Helen, you had any other opinions about physician champions, or potentially how to work, or how you've worked with physician champions if they don't have all of these, you know, ideal attributes.
Oh, yeah. This laid it out really well, how important it is to have a physician champion. I know, you know, at one of our critical access hospitals, we have someone who's not, you know, we don't have an ID physician there, so their pathologist is leading their stewardship program. So he's, you know, just enthusiastic and can kind of drive the program forward. So even without having the ID expertise, it can still be done. So.
Absolutely. the ID expert is nice, but if that's not an option for you, work with what you've got, and just having a passion for it is a big deal too. And I see we've got a question here. Are physician champions paid for this position? I would say sometimes yes, sometimes no. And in my situation, our physician champion was not initially paid, and I will say that he was a physician who was sort of nearing his retirement and trying to slow down his practice, and he was involved in this because he thought it was important. But there were certainly days where he felt overworked and overwhelmed and underappreciated. And there was one particular day where I was trying to get him to work with our pharmacist at the early stages of developing our program. And he just kind of threw up his hands and was like, oh, the hospital isn't even supporting me in this. I don't want to, I'm not putting in any extra time to do it. And after that, he came back and we ended up being able to work this out. But I did go back to putting together a small business model. It was sort of a simple version, but some justification for why our administration needed to support us in this. And we were able to get him some money. I think it was something like he was getting paid like 5 hours a month or something like that. And it was probably not as much time as he was putting into it with us. But just the token really satisfied him and helped him, agree, kind of pushed him to agree to keep working with us and keep doing with us. So some physicians do get paid for this. Others do it because they believe in it. Ideally, in order to keep people motivated and to keep them committing their time, if you can get pay or work towards getting paid for them, that is ideal. And that goes back to kind of the business model thing and getting your administrative support. And I don't know, Helen, do you have anything to add to that?
Yeah, I agree, Erin. I think whatever you can get for them, try. And we know these physicians are overworked. Some of them are going to, several hospitals in a day. And so to just, to ask them to be accountable for a program, it's sort of one of those, you get what you pay for, so any sort of reimbursement financially will help improve the accountability of that. And a model that I had in my previous institution, which was also a community hospital, was our physician leader got paid for leading a committee. So they might already have these contract models in place of like whatever physician is leading another sort of committee at your hospital and can pay them the same. I think it ended up being like 0.08 FTEs or, something really small, but it was something. But I do think it's important to try to get these physicians compensated.
I think that's a great point, Helen. There's also resources, and I think including some of the materials that Erin already shared that IDSA and SHEA have that kind of give a going rate too. So if it would be of interest to the audience, we might be able to summarize some of that information in an FAQ or educational material that stewardship pharmacists could use to try to convince their administration that the standard really is to pay these people, and this is what the recommended going rate would be too.
Absolutely. I like the you get what you pay for. You're definitely going to get more cooperation from people if you can get compensation for them. And it is a lot of work, so it's only fair that they get paid for their time because everybody is busy and overworked, and it's really hard to commit to something if you're not getting compensated for it. The next step that I wanted to talk about was developing relationships, and I will say, at least in my role as our leader of the antimicrobial stewardship program at the hospital I worked at, this was probably the biggest thing that I did, or the most important thing that I did. Oops, hang on, my slides are not moving forward now. There we go. So while I start to talk about that, I wanted to have you guys just type in who are the members of your ASP, who is helping you, and who's a member of your team. I will tell you that we ended up, the way we set up our program, we had the day-to-day work. We actually divided among some of the pharmacists who we supported and gave some additional training and infectious disease and the particular projects they were working on. And they did round with our ID physicians as much for their education and their relationship development as anything else. We didn't have a big ID service or ID team, even though we did have a few residents and a few medical students at our hospital. The ID program was not a huge part of that. And so a lot of times the ID rounds, it was just the ID physician and the pharmacist. And honestly, our pharmacists who were just beginning sort of their infectious diseases career, they didn't add that much to the ID rounds initially, but they learned so much. And what they were doing was we were focusing on 2 particular drugs. And so they would look before rounds at who was on those medications and the interventions they were making, or maybe ones they had made the day before that had not been accepted. They would go on ID rounds. They would meet the physician in the microbiology lab. And then they would go and see the patients that had an ID consult with the ID physician. Most of that was our pharmacist learning and the physician and the pharmacist kind of developing their relationship. And then after those rounds were over, the pharmacist would bring their antibiotic stewardship issues to the ID physician. And occasionally they would go and see a patient together. Other times the physician would just give the pharmacist some input on how something should be handled. But getting them to work together was a really big deal, because while our ID physicians in our institution had a really good relationship with the pharmacists that they knew face to face, so the sort of the more administrative types who went to the committee meetings, they did not have a great relationship with the pharmacists that they talked to on the phone. And like I said before, they kind of ran a tight ship, and our pharmacists were very intimidated by them. And so there were some pharmacists, when we asked them about participating in a stewardship program, that just didn't even want to do it. But that we did have a handful that were, and so we utilized those people. And a big part of what I had to do was get them to come together. And I knew if I got them face to face and could get them interacting face to face, that the physicians would see that the staff pharmacists that they'd maybe had some frustrating interactions with before were really trying to do the best things for the patient. And they really were trying to do a good job and wanted to do a good job. And our pharmacists were telling me, I don't want to go out on a limb and then not be backed up by ID. So we had to come up with some guidelines, make some agreements between the ID physicians and our pharmacists about what we were going to be doing, what interventions we were going to be making, what we would refer back to the physicians. But getting them in a room talking face to face was a big, big deal. And we actually ended up getting our ID physician to come and do kind of a general lecture and a general introduction to our pharmacy staff. And that was kind of a big coup to get everybody in the same room talking. And then from there, we worked on developing those relationships. I'm looking here at everybody's responses. It looks like we've got pharmacists as being sort of probably the most common there, person that's on your stewardship team, physicians, infection control, some folks from the lab, pathologists. Who else have we got here? Education, administration, quality, ID, directors. So yeah, a lot of you've listed a lot of the people that are important to have on your team here. So I'm glad to see that you all are getting other people from other departments involved. What I've got here is sort of what our team looked like. I co-chaired the committee with our physician champion. We had our director of the microbiology lab, who was a pathologist, and then we had also the head lab tech, who was able to help us as well. We had infection prevention represented. So we had both of our ID physicians on the team. One was the leader with me, and then our infection prevention person was also was our second ID practitioner. We also had the nursing staff, the infection preventionists, who were doing sort of the day-to-day work of infection prevention and control, were part of our committee as well. We had nursing represented. We had the pharmacists who were going to be doing the day-to-day work, as well as some of our more administrative types in the pharmacy. We had our administration representative was sort of an administrator over the quality department, so she was kind of a two-in-one representative for us. IT was part of our team, although they didn't actually come to our meetings, and if I had stayed with that hospital, that would have been an area I would have needed to focus on, because we probably needed more IT support than we had. We had a hospitalist there, an ED physician there, and we did have residents at the hospital, so we had resident representation as well. So at our big monthly meetings, not all of these people necessarily brought us issues every month, but a lot of what happened was they would hear what was going on, and they would hear what we were talking about, and they would take that information back to their staff. We certainly wanted them bringing us information and problems and things they were seeing on the floor that we could address, but a big part of their role was to be a part of the team and help spread the news with others. I will say our hospitalists were some of the prescribers that we most needed to kind of encourage them to change their practice. So having them be part of our monthly meeting was really helpful, because sometimes when you're talking to a physician about a specific patient, there's more defensiveness involved. And when you're talking about kind of an abstract, just the idea of how you would manage something, some of the emotion and the defensiveness isn't there. So having them as part of our team and coming to the meetings and seeing kind of overall what we were trying to do helped us get their buy-in a little bit more. So that was kind of what our team looked like. So to get our team up and running, the relationship building I already mentioned, that was a really, really big thing for us. We had to support our pharmacists and get them ready, because they were telling us that they didn't feel ready to do this work initially. So we did set up kind of some educational sessions with our ID physician and the pharmacist. We had one kind of big evening meeting with them where we got dinner for everybody, and he came and had like a lunch conference with us a few times. I was doing the MAT ID certificate training at the time, and so I was sharing all of those CE that I was doing, all that CE that I was doing with our pharmacists, and we would eat lunch together and go through those webinars together so that they could, get as much education as possible. And then the daily rounds with the ID team, I already talked about how that was helpful for relationship building and for educating our pharmacy staff. We were adjusting our pharmacy staffing model at the time to a more decentralized model. So we were able to kind of work into that adjustment, getting a little bit of time set aside for an antibiotic stewardship pharmacist. And the way we worked it was we had initially 3 pharmacists who were really into this. And so they would be fill an antibiotic stewardship pharmacist role for a week, and then they would rotate. So every 3 weeks they would be on, and they would have at least half their shift dedicated to antimicrobial stewardship. And sometimes they would get a few hours back in the afternoon that they could come and help as well, depending on how the afternoon staffing went. Getting IT support to help us with some of the reports and the tools that we needed was important. And then getting the word out to not just the pharmacy staff, because we were kind of intimately involved in this, but to the medical staff, so they knew what was coming. That was a big deal. And so we did get in the grand round schedule and kind of give a general antimicrobial stewardship talk, and then let people know kind of where we were planning to start so that they knew what was coming.
Erin, I was wondering if we might get some opinions from Helen about the pharmacy staffing model too for some of the smaller BJC facilities in terms of how they adjusted things as well. Helen, can you comment, or do you have any additional thoughts on the pharmacy staffing models for smaller hospitals, and what's worked and what hasn't worked?
Yeah, it's challenging at the smaller hospitals. Our smallest hospital, they have 1.5 FTEs. and, no ID physician there. So, they're doing all the clinical work, not just stewardship things. So any kind of clinical decision support things that I think can help make the workload easier, sort of more black and white things to intervene on, like redundant therapy, dosing, IV to PO. And this is where, we can this is probably coming later in the presentation, but, engaging nursing more. So it's really a team effort at your smaller hospitals like that. Is that what
Absolutely.
you're asking?
Yeah, I was going to say that's kind of a good segue into choosing attainable goals too. You mentioned the IV to PO as a place that kind of a more black and white. You can get your IT support, you can run reports and sort of see who might be eligible for some of these interventions. That's important, and I think it's important for all stewardship programs as they're beginning, but it's probably exponentially more important in your smaller hospitals that don't have as much staff to dedicate to this. When you read all the antibiotic stewardship literature, at least for me, it's easy to get excited about all the potential the potential good that you can do, the potential interventions you can make. And it's easy to get carried away, and it's easy to get overwhelmed by all of the potential. And so when you're starting, it's a good idea to choose something attainable, thinking about your staff and what they can realistically accomplish in a day. And, thinking about the impact. So kind of maximizing the impact while not overwhelming your staff is the balance that you have to strike. I put a couple of references on the bottom of this slide that are from the primary literature. The first reference that is low-hanging fruit worth picking for antimicrobial stewardship programs is kind of a nice paper. It's from a few years ago now, but and basically she kind of says that you can achieve some significant benefits by making some of these easy interventions. And I think she talks about IV to PO switches in her paper, and she's got some other examples as well. And hopefully, if you choose something that you can do, that you can actually accomplish with the staff that you have and can fit into your workday, and you can show some success with that, and with some of these interventions that should be sort of considered low-hanging fruit, you can really show some success, hopefully fairly quickly. Taking that to your administration to help you get more support is a kind of a good plan. So start with kind of the easy stuff, show some success, and then take that to your administration, and you can show them that there's other things we could do, but with our staff, restrictions, this is all we've got time for right now, and we'd like to do more things. I will say too that while cost savings is not ever really a goal of antimicrobial stewardship, it is often a side effect of antimicrobial stewardship, and it is a thing that administration is often interested in. So, if in that paper by Dr. Goff, she, I can't remember now what the numbers were, but they were able to show a pretty significant financial savings by making an IV to PO switch a more systematic process through their stewardship program. And they were able to take that to their administration and show them some fairly significant cost savings, which catches the eye of an administration for sure. The second paper there is actually part of a whole supplement that the CID journal did on antimicrobial stewardship. And it's by one of the same authors there, where she describes 8 habits of highly effective stewardship programs. So that's just another good kind of reference. And I think she also talks about the kind of low-hanging fruit and some good places to start that maybe are less labor intensive. For us, in my experience, what we did, we knew from our buying group that we were a part of that our use of piperacillin, tazobactam, and vancomycin was way, way, way out of line compared to other hospitals, even hospitals that were much larger than us. So that was where we chose to start, because we knew that that was an area that was, there was a lot of potential for improvement there. So we developed some appropriate use guidelines. for both drugs. And then we also developed some monitoring guidelines for vancomycin use. That was mostly because our ID physicians and our micro lab were really, really tired, or our lab were really, really tired of doing unnecessary and useless vancomycin levels that were ordered inappropriately, drawn inappropriately. So we wanted to put some guidelines out there for when to draw your vancomycin levels and how to interpret them and when they need to be ordered. So that was all kind of a package. We started with the piptazo intervention and then quickly added the vancomycin intervention as well. And we did that by, just running a report from our pharmacy database that showed us who was on those drugs, and it had the start date on there so we could see who'd been on them for 72 hours and then review those charts. It also had the micro information there so we could see culture results. It made it a little easier for our pharmacists to kind of quickly make assessments and see where they needed to focus their energy. Let's see. Yeah, do you have anything else? Does anybody else have anything they'd like to add about attainable goals, or especially in smaller hospitals?
Yeah, Erin, I think those are great points. One of the other things that I think you can also do to find attainable goals is find goals that align both with stewardship and infection prevention. So trying to reduce inappropriate culturing, trying to reduce blood culture contamination rates are of interest both for infection prevention and antimicrobial stewardship. And infection prevention may already be monitoring a lot of these things anyway. So if you're having trouble getting IT support or other things like that, with their existing reports, you might be able to demonstrate improvement in other metrics that are also associated with inappropriate antibiotic use as well.
Yes, absolutely. Looking at what other groups within your hospital are already doing is a big help and a good idea. So this slide, I'm not going to go over a lot on this slide. I've just described sort of the details of how our program worked, but what I want to point out here are the references at the bottom. The first reference is just an example. It's one paper that was published not too long ago in the American Journal of Health System Pharmacy, where they describe sort of the evolution of an antimicrobial stewardship program in a smaller community hospital. And they kind of talk about how they started with having sort of all the antibiotic stewardship duties given to one pharmacist, and then how that person was kind of the clinical coordinator, antibiotic stewardship person. But they often got pulled to committee meetings and other things, and they weren't able to necessarily review the patients every day. So they ended up shifting the work and dividing it among the pharmacy staff and making it part of the daily workflow, and how that was much more successful for them. And then they picked some of that low-hanging fruit and focused on just a couple of interventions that they could work into their pharmacist workflow, and were able to show some success and some cost savings that they could take back to their administration. So that's a nice example in the paper or in the literature. The second paper there is really cool because it describes some case studies. So in that paper, they kind of, in their case study section, they describe, they have hospitals of different sizes. So they have a tertiary care center, they have a critical access hospital, they have a community hospital. And they also talk about within each of those settings, different sort of staffing structures and political structures, things that might be going on, and how those things will affect how you design your program, because the program is going to be different based on the staff you have, the size of the hospital you're in, as well as some of the politics and staffing structure and support that you have. And I like that this paper described about 6 different scenarios and different ways that they designed their programs. So that's kind of a nice example of some different options. The next thing I wanted to talk about was reporting data and gathering data. I will say I don't have a whole lot of specifics here. This is an area that I know is a big struggle for a lot of pharmacists, because a lot of the data we're trying to get or we need isn't necessarily stuff that we have access to within our pharmacy modules, within our computer systems we're using. I will refer you back to that initial reference that I talked about from the Joint Commission Resources, the Antimicrobial Stewardship Toolkit, where they have a whole module on metrics. I will just say this. This could be a whole talk unto itself. But as a general statement, I will say some data is better than none. And so when you're talking about what needs to be reported externally, like NHSN and organizations that we're reporting to, that's a whole separate talk. What I'm talking about here is what you're using internally to show your effect of your antimicrobial stewardship program. And I will say, for us, when we got started, it's important not to get hung up on the ideal because the ideal can be very hard to get. So balancing data that's useful with data that you can easily attain is sort of a balance you have to strike. I will say talking with other departments and committees is a good idea. Your quality department, at least ours, they were collecting so much information anyway, and they had connections to all kinds of different areas that I didn't have connections to help me figure out how to collect data. So, talking to someone in your quality department to help you with your data collection needs is a great place to start. We needed to get data from our lab, so having a resource there when we were trying to show a change in the utilization of vancomycin levels for us was, that was one of the things we were intervening on, and we wanted to see if we were making a difference. So having a lab connection was good. Infection prevention, like we talked about, they're monitoring a lot already. So, using them and sort of sharing information with them and getting information from them is helpful. IT support is really big here. That was an area that we struggled with, was getting IT support and really having it just be a priority for them. We were usually bumped down to the bottom of their list. I think having the Joint Commission mandate might have moved us up some, but I wasn't there when that happened. So I will say, we used our drug purchase data, which is kind of very vague. There's a lot of limitations to that data. We use that to kind of identify areas that we might need to look further into. Drug administration data, is much more valuable. For us, we could really easily run a report of doses dispensed from the pharmacy module of our computer program, but there's a lot of drawbacks to that because there were doses returned and doses that maybe didn't get credited and missed doses that were dispensed more than once. Getting data out of your dispensing machines, if you have unit dose dispensing machines, that was what we ended up using for a lot of our figuring out how many doses we were dispensing of drugs. If you have an electronic medication administration record that you can actually get data out of, that's great. We weren't able to get a lot of data out of ours. Maybe that's changing, and I'm sure that's better with different, better or worse with different programs. And then I already talked about lab a little bit, but being able to track pharmacy interventions was useful for our pharmacy director when he was trying to justify staffing at least a partial daily shift with an antibiotic stewardship pharmacist, knowing that they were actually making interventions that were being accepted was useful. So figuring out how to track those interventions is a good idea. The last thing I will say is be visible. We did a lot of things to try to make sure people knew what we were doing. It was really great when our ID physician and pharmacist were up on the floor and people would see them together and they would just see them and say, oh, who do I have on Zosyn? Who do I have on vancomycin? Who do I need to change to PO? So, we really tried to get out there and let people know what we were doing. And I've got on my slide here lots of different ways that we did that. And reporting data back, you need to report that data up through your administration and through your committees so people can see what you're doing and hopefully see the successes that you're having. So that is sort of the end of my part. And Kayleen, I am so sorry we went longer than I was supposed to. Let's carry on.
Not a problem. So this is Colleen, and my expertise in stewardship is actually from the international setting. I'm just going to tell you very briefly about myself and expertise, ask you a couple of questions, but just because we are very short on time, we are going to keep my slides for another webinar. So I basically work with the World Health Organization on antimicrobial resistance and the implementation of stewardship in low and middle income countries where, as you can imagine, there are smaller hospitals and sometimes even larger tertiary care centers have limited both human and financial resources for stewardship. So there's that part. I'm also working with the IDSA's Global Stewardship Project, which is a new project using telemedicine for international stewardship as well. What I had planned on talking about is some of the CDC guidelines that may be useful for smaller hospitals, but at the same time detail some of the best practices that we have learned from potentially low and middle income countries as to what worked and what are some stewardship interventions that either use very limited resources or even limited human resources that you can think of potentially implementing in your facility. So having said that, just because the time is short, what I would like to ask you is, we're still going to talk about my topic in another webinar, but what would help me as well is if you have any interest in us tackling the scenario that you have in your hospital and what are potentially some intervention that may work. For example, if you're in a hospital that has one pharmacist who's not dedicated to antimicrobial stewardship, maybe no micro lab on site, maybe someone from infection prevention contributing to stewardship. If you would like to hear about some suggestions for that scenario, if you could email us at the address for this stewardship initiative, so missourimo.stewardship@russo.edu, which you're going to see at the end. This would help me also elaborate further on maybe some case studies that would be helpful to you. So that's my contribution for today. I would like to ask you, though, we still have one poll everywhere, so one slide where we would like to ask you about the topics you would like to see addressed during the presentation on multi-drug resistant organisms, and this is to help Jason Burnham structure his lecture even better. So if you don't mind taking a couple of minutes to give us the answer.
And also, this is Megan Pilar here. I also just want to add to what Colleen said. If there are any specific questions you have related to actually implementing ASP in your hospital, or any specific questions, like I said, related to implementation, please feel free to throw those out there. I know we're short on time today. Maybe that's something we could come back to on a later date, but we're always happy to answer those questions as well.
Absolutely. Thank you, Megan. I think we're really trying to see what are the things that would be of most interest to you, and then restructure the upcoming talks based on your interest as far as materials and topics. So please, by all means, do not hesitate to send us your thoughts.
I will say too that I was not able to get the slide in here that had the feedback. And so I'm hoping, and maybe Mike, if you're on, or I don't know if Kevin is on, we can send that feedback survey out via email maybe to the people that are listening.
Yeah, Erin, I think that's a great idea. We can work with Megan to send out an email link to get feedback about how this presentation went as well.
Okay.
Yeah, I think that's a great point.
And while you all are putting in your comments here about your multi-drug resistant organism questions, I will just reiterate that we do have that mo dot stewardship at Wustl, WUSTL at edu, where you can send us questions, you can send us ideas for presentations, and we do check that regularly and we'll respond to you. And, we really do want your feedback, and we want to make our presentations as useful as possible for you guys and give you guys the information you need. So please use that email. Which is great. It looks like we're getting lots of ideas for our multi-drug resistant organism presentation. And it looks like we've got a question submitted about oral de-escalation protocols. So that can be something maybe we can address either in a future presentation or through an FAQ, if that's something that you guys would like to hear about. And I think, we can leave this poll, ev.com, the poll everywhere slide open, so you can continue to put in your responses. But I think that concludes the content of our webinar today. Kayleen, again, I am so sorry that we didn't get to hear more of your presentation today, but I know everybody will be really excited to hear it at another webinar.
Not a problem. I'll get more time.
Okay.
All right. Well, I think we'll wrap things up then. Thank you very much, everyone, for attending. Great job, Erin and Kayleen, for presenting and sharing your experience. I want to thank Helen Newland for participating too. I thought your insights were very valuable. And we will be sending you another link about getting feedback from this webinar as well. So please tell us what worked, what didn't, and what you'd like to see in future webinars on just the topics that we've seen too. So thank you very much for attending. Thank you, Megan. We'll be sending you an email with that Poll Everywhere link to distribute as well.
Okay, sounds great. Thanks, everyone. Have a good day.
Thank you.
Thank you.
Bye.
So just one final reminder for those still responding to the poll on the screen. That will stay open, but we will close the webinar now, so your screen will change. But otherwise, have a great Friday.